Okay, today I'll be going over management and care of a patient with a recently placed ventriculostomy. I've listed some key objectives and findings that I'd like you to take away from this presentation. At the end of this, you will have gained a greater sense of what a ventriculostomy is and how to care for a patient with one, including indications for a placed ventriculostomy and how it works. We know that the goal of a ventriculostomy is to monitor intracranial pressure and drain cerebrospinal fluid. So before we really get into talking about what a ventriculostomy looks like and how it works, it's essential for us to go over what intracranial pressure is. So intracranial pressure is a measurement of force exerted within the brain's ventricles and cranial vault. And it's created by cerebrospinal fluid, brain tissue, and blood. And we know that cerebrospinal fluid is essential because it bathes the brain in nutrients and essentially feeds and nourishes the brain all the time. And when there's a change in volume in the brain, so when we see a change in brain tissue, blood, or cerebrospinal fluid, compensation occurs and pressure in the brain increases or decreases. The goal is to maintain an ICP between 5 and 15 millimeters mercury. When a patient has an ICP greater than 15 millimeters mercury, we see symptoms of elevated ICP. So this looks like headaches, nausea and vomiting, any changes in level of consciousness. When a patient has an ICP greater than 20 millimeters mercury, we start to see changes in vital signs, and this is when intervention is really important to prevent a medical emergency. So I've listed some indications for ventriculostomy placement that bring about elevated intracranial pressure. Essentially, what these have in common is that they are any condition that shifts the ICP. So these are either a mass, hematoma, or edema. And the most common is the first one I listed is hydrocephalus. It's really important to change that rising amount of fluid in the brain to decrease that intracranial pressure as soon as possible. So now that we know some indications for a ventriculostomy placement and what ICP is, we can start to talk about what the ventriculostomy is itself. So it's also known as an external ventricle drain, and it's a closed catheter system that allows for drainage and measurement of cerebrospinal fluid. This device is unique because it allows us to not only monitor the ICP with a monitor placed just outside the borehole created before inserting the catheter, but it also allows us to drain cerebrospinal fluid. There's a lot of other devices, such as the Codman monitor, that don't actually drain the CSF, but they do allow us to see and to monitor the ICP. So draining may be continuous or intermittent, depending on orders and severity of condition. When the draining is continuous, the physician will actually set a parameter within the drainage system, and whenever the pressure in the patient's brain reaches above this parameter, it will create a vacuum and the CSF will drain. When drainage is called for being intermittent, it's really important that the nursing staff really have a good understanding of what this means because it's basically autonomous for the nursing staff. So a 3-way stopcock is open for brief periods of time, usually between 30 and 120 seconds, until the pressure is below the patient's upper level parameters, usually less than 15 millimeters mercury. And these parameters may be less than 20 millimeters mercury if the patient is being monitored in the ICU very, very closely. We always want to monitor patients with ventriculostomies closely. When the stopcock is opened, CSF will drain from the ventricles into the drainage bag, which decreases the intracranial pressure. I like this picture because it offers a couple different ways of monitoring ICP, but like I said, ventriculostomy is the only way that we can really monitor the ICP and simultaneously drain CSF. So we also have an intraparenchymal monitor as well as a subdural monitor. This picture offers kind of another look at nursing care with ventriculostomy. It's a very hands-on, very critical thinking tool that nurses must be comfortable using and be very familiar with. You can see that the transducer is at the level of the patient's ear tragus. This is important because we don't want to move around the pressure transducer, which could create a vacuum and give us an erroneous reading of ICP. So ventriculostomy is placed sometimes intraoperatively, but usually bedside, and a burr hole is created, usually in the right frontal cerebral hemisphere, and the catheter is guided into the right ventricle. I've listed some important nursing management. The pressure transducer has to be level with the ventricles. This means that the pressure transducer must be at the level of the patient's ear. And before moving the patient, it's essential that we clamp stopcock. This is important because if the patient stands up, we will have a falsely high ICP. The CSF will drain too quickly. It'll go from the patient's brain into the drain, and we are left with a potential for collapse of ventricles, which is a medical emergency. If the patient's tragus falls below the level of the pressure transducer, we'll see a falsely low ICP, and CSF will not drain. It will actually back up into the ventricles and create a headache and a huge potential for infection. Documentation is really important for this. Documentation and communication with other nurses is so important. It's key to reducing pressure and preventing oxidative symptoms. So for this reason, it's essential to get to know the patient, establish a baseline, really be familiar with what their range is for ICP. And dressing changes are essential because infection is the #1 complication of an ICP. So we want to be constantly monitoring that infection site for signs of infection, the catheter site for signs of infection. And probably another more important nursing management is zeroing the transducer, and this recalibrates the transducer to the monitor, and it avoids getting those too high or too low ICP readings. So many ventriculostomies are equipped with a laser pointer, so you can actually point at the level of the patient's tragus. At UW, the ventriculostomies that they use do not actually have a laser, so it's really up to the nurse to eyeball where the patient's tragus is and where the transducer is. Again, I've listed some really common complications, #1 being infection at the catheterization site, usually due to skin flora getting into that burr hole. So we're looking at Staphylococcus aureus, and really frequent dressing changes and monitoring of that site are very important for cardinal signs of infection: redness, warmth, swelling, and inflammation. And one of the more fatal complications is fatal meningitis as a result of the placement of an EVD. So this is another infection. It's also known as ventricular meningitis, and once this has set in, it's very, very difficult to treat and usually fatal. Every location will have their own assessment requirements for nursing management, but it begins with bedside reports and really going through a neuro assessment, going through orientation to time, place, and then understanding if does the patient understand the situation. Monitoring movement, monitoring cranial nerves. It's important to establish the patient baseline early and be wary for signs of elevated ICP. These look like confusion, headache, vomiting, irritability. Often the first signs of an elevated ICP are a headache and just the slightest change in level of consciousness. So again, it's very important to monitor, to establish a baseline for what the patient is. And it's important to monitor tubing for signs of blockage. This may lead to a sudden severe elevated ICP within the ventricles. To check for blockage, nurses should slowly lower the drainage system until it's below the patient's tragus and watch for slow drip collection in chamber. Like I said, it's very important to do so slowly. Doing so too quickly could result in a headache and confusion for the patient. So when you're doing this, it's important to explain to the patient what you're doing. If there's no drip in the collection chamber, this probably means a blocked tube, and call the MD right away. So wrapping up this presentation, there's some key considerations I'd like you to take away. Like I said, patients should not move without speaking to a nurse and without the assistance of a trained nurse aide with a ventriculostomy or a nurse. And looking at cardinal signs of elevated ICP, so confusion, headache, establishing a baseline, really knowing how that patient is how he or she was last night, and what he looked like at the beginning of the shift especially. So this has been a brief presentation on care for a patient with a recently placed ventriculostomy. I've listed my resources for pictures and information here, as well as this next slide. Thank you very much for listening.